some key things that will change. Emergency waivers that have allowed expanded access to care under Medicaid will go away at the federal level. Millions will lose health coverage unless their states choose to continue waivers. CDC will no longer have the authority to require data from labs, hospitals, and other providers. Also, if a proposed DEA rule is enacted as written, health providers will no longer be able to dispense medications for opioid use disorder without an in-person interaction, putting thousands of lives at risk. So again, what we want to talk about today are bright spots from the pandemic, things that we were able to do due to an emergency declaration that we weren't necessarily able to do previously, and that we really should keep on doing. So our speakers today will share their perspectives and outline those things that we need to ensure, those gains that we need to ensure we don't squander around the opioid epidemic, especially medically assisted treatment, access to health coverage and associated medical care, as well as things like SNAP benefits, and also data authority and modernization.
The public health pandemic loosened or removed other federal rules that we found so helpful to increasing treatment flexibility, resulting in improved treatment outcomes. I want to share just a couple of local examples with you. In terms of access to one of our most important life-saving medications, methadone, which has requirement both at the federal and state levels to require people to come in to receive medications on most days, the pandemic emergency allowed us more flexibility in what we call take-home dosing. Our providers in San Francisco observed that these take-home doses have helped retain people in treatment. And before COVID, roughly 25% of our patients qualified for a take-home dose. But after easing of regulations, 82% received at least one take-home dose. This change has been studied across the country, has been found to be safe and effective, as well as encouraging of patient retention and care and patient and provider autonomy. Another local innovation that we were able to make in the context of the COVID pandemic, and one which is so vital, we believe, to increasing access both in rural and urban areas. And that is the issue of mobile methadone. One of our opioid treatment programs, or methadone programs, was able to expand from a relatively small clinical space at our local hospital campus to changing to provide services using a mobile van and usually using a specially equipped Zoom booth in the parking lot. We now have 3 mobile methadone vans affiliated with our opioid treatment program. And San Francisco is the only county in our state and one of the few in the country that has such a mobile methadone clinic. We know that during the pandemic, some of the regulations to establish mobile care were relaxed, and we offer and hear and want to continue this as much as possible, and believe this is really vital to increasing flexible and patient-centered care. There is momentum for these regulatory changes to be made permanent, and this is a major step for us, as well as colleagues across the country, in reducing barriers to this life-saving medication.
Tennessee is one of the 10 states that have not opted to expand Medicaid. TennCare, Tennessee's Medicaid program, covers approximately 1.7 million Tennessee residents, mostly low-income children, pregnant women, and people with disabilities. Childless adults in Tennessee are not eligible for TennCare, regardless of their income level. If Tennessee accepted Medicaid expansion, an estimated 220,000 uninsured adults under age 65 would become eligible for TennCare. The cost of Tennessee foregoing Medicaid expansion is borne on the backs of low-income, childless adults who are disproportionately people of color. It's estimated that 6 in 10 of the people who fall in the Medicaid coverage gap in Tennessee are people of color. The cost of our state government's inaction on Medicaid expansion is also borne by healthcare providers. 16 hospitals have closed in Tennessee since 2010, most of them located in rural areas. An estimated 75% of the remaining rural hospitals are at high risk of closure. The closure of rural hospitals spills over to impact hospitals in urban areas like ours, including my hometown of Memphis. The Elvis Presley Trauma Center at Regional One Health is the only Level 1 trauma center in a 150-mile radius of Memphis.
The COVID pandemic, certainly showed the importance of timely and accurate public health data. I'm sure many of you, for the last 3 years, were reporting on these numbers daily. We remember these days of looking at whether the numbers are going up, who it's affecting, I say trillions of dollars worth of decisions were made based on this data, and whether we were going to shut down businesses or schools or require masks and all these things. And so, the public health emergency declaration gave CDC temporarily authority to require states and locals providers to provide this data on surveillance, testing, hospitalizations, vaccinations, deaths. But after May 11th, now CDC can continue to request this data, but it can't require it. And so we really would like Congress to grant CDC this authority to collect this, because again, if we've seen for COVID, it was so important, but for whatever other conditions, and we may have in the future, we need to have this authority and ability to provide this timely data. In turn, state and local agencies, we need better line of sight into this individual level data. As I mentioned, vaccinations, the pharmacies or some of the providers, others, to be able to really see what's going on. I know in Dallas, we've been looking and getting daily accounts of who's been vaccinated. We can put it on GIS maps and see where it is. We've actually been every 2 weeks producing a census block level report on which census blocks had the most number of unvaccinated persons, and targeting our pop-up clinics, community outreach, and vaccination efforts to some of those areas.
I'm going to take just another brief moment to close with a few notes about what we would like to see, we BCHC, happen at the federal level to support the work that's happening on the ground. So as Phil mentioned, we need sustained federal funding. We need it committed to emergency preparedness and to building a well-functioning public health system at all levels of government. Funding is still too slow and too inconsistent. The boom and bust cycles for emergencies, the discussion of clawing back and redirecting funding when an immediate crisis is over, which is not unique to COVID. We saw this happen when we took Ebola money to respond to Zika several years ago. And the ongoing debt ceiling debate is really not consistent with building the system we need. This year's budget cycle also threatens to send us back years. If we do go back to fiscal year 2022 budget numbers, which has been discussed in the House, that'll be particularly catastrophic for what you can see on the screen here, FEP, which is the Public Health Emergency Preparedness Program, and HPP, which is the Hospital Preparedness Program. These are federal dollars specifically meant to prepare state and local jurisdictions for emergencies. So we need to make sure that this funding is maintained and moreover increased. And if we don't learn this lesson now, while COVID is still a leading cause of death, I'm not sure when we will. Additionally, there are real policy changes, if we go to the next slide, that Congress also needs to make and can make so that we can more effectively protect the public's health. So again, those include extending telehealth flexibilities for opioid use disorder treatment, just as they've done for other areas of telehealth, and end requirements for in-person visits to opioid treatment centers, and they can grant expanded data authority to CDC. Finally, we also encourage states to be thoughtful in their process of re-enrolling Medicaid recipients. As we said at the beginning, we really have an historic opportunity to learn from this devastating pandemic that has cost us more than 1 million lives. Big city health departments know we must keep innovating to stay ahead of the next public health emergency, and we need to ensure that they have the support to do just that.